responsible for the hemorrhage. So there are various techniques are available which can cause, which can be used for blocking aneurysm. We have to, just like in angiography, the this what we can say wire and the probe, it reaches to the area like that, it will reach to that area wherever this aneurysm or blood vessel broken is found. At that time some sealant will be used, and that sealant will be sealing first. That will be different type of sealant which will not be affected by this TPAs or anticoagulants, and this is done first and then TPA can be used. So that is a very complicated procedure these people can have. Age should be less than 80, because after 80 it is very difficult, or it cannot be useful. The major infarction, if it is there, the parenchyma hypotension or brain swelling should be less than 1/3 of the this mid cerebral artery. MCM is mid cerebral artery delivery. Then that NIHSS score, that is should be less than 22. MRA score should be greater than 2. BP should be less than 185, and the patient should not be on warfarin or heparin. Platelets and coagulation should be normal. Then we can give, because otherwise again you have to work hard, you have to calculate everything. If the patient is already on warfarin or heparin, because anticoagulants are there, and then you are adding this RTPA, then it should be a problem. So that has to be taken care, and then accordingly the treatment has to be planned. So then surgery, it can one can go for, as I told you, various surgery, but surgery is not a preferred one. This is algorithm when surgery can be preferred. We know there are two types of stroke, either it can be ischemic, it can be hemorrhagic. Now surgeries are of different type. One surgery we have seen, we call it as a decompression. What is decompression surgery? Anybody can recall? Can anybody recall what is decompression surgery?
Sir, it is usually done when the brain, means the skull, it doesn't have the space to spread in case of inflammation. So that is, in that condition, it is decompression surgery is done.
Okay, what is done in decompression surgery? Simply what is done is simply, yes Pooja and Pratima, it is simply the skull portion, some of the portion of the skull is removed, it is separated because it is tightly locked, it is separated, so that whenever there is a severe inflammation is occurring, and what will happen because of that, this severe inflammation in the skulls, that will cause compression, and therefore there should be a decompression. बर चारपर्यंत बंद आहे, सांगितलं तुम्हाला तसं. ठीक आहे सर, ठीक आहे, मला पाठवून दे तसं वाटतं एक मेसेज. संगीत आपण का? बरं, चला काळजी घ्या. चला. So now again this will, when it will there, whenever we try for treatment with ischemic, whenever we go for given RTP, this recombinant tissue plasminogen activator, then once blood flow will start, immediately the inflammatory signs will be there, and then we need it, that decompression is there. So immediately that decompression, in any case, whether it is hemorrhagic, whether it is ischemic, if decompression is one type of surgery. Another is a hydrocephalus, is a condition where the aqueous portions or watery portions are accumulated in the brain. So for that, that evacuation of hematomas, that is clotted blood is there, we call it as hematoma. Then ventriculostomy, both, or there is an aneurysm, then we have to, as I told you, seal the aneurysm. These are there. Now these are very typical one. Again, it treats. These are these are actually opted when it is really required, because that is a big problem, and in that condition, the ventriculostomy is there. That is, this all the ventricles are there. In that, we are going for administration or just sealing the portions, and we have to go for the minimal invasive surgeries, because nowadays laser guided probes are there, and with that minimum invasions are there. Particularly, these are required in a typical additional surgery. In decompression, it is not a big surgery, it is just removal of skull, or craniectomy we call it as a, and that is okay. And as soon as decompression is there, as soon as it comes back, inflammation is over, it can be again given back. Now, so these are various surgeries are there, and whether if there is a lobar hemorrhage, there are no big evidences that shows very big benefit, and if the patient is stable, so it cannot no difference in the outcome in the stable patient, but surgery outcome will be better than conservative treatment in progressive neurological deterioration. If neurological deterioration is there, then surgery is useful. If there is a hemorrhage in the vessel ganglia area, and then endoscopy, evacuation better than conservative treatment. Evacuation already we have seen. Evacuation means suppose water is logged in, blood is logged in the hemorrhage, or hematomas it is formed, then just evacuation, that is removal of with suction of that. And cerebral hemorrhage is there, then it is a surgical with hydrocephalus, that is presence of water into that, accumulation of water into that, that is it requires a surgical emergency, and it has to be done. So there are various kind of surgeries are there, and they have given the outcome that shows that this surgeries that stitched was a trial surgical treatment of intracerebral hemorrhage. So if it is done, then it can be benefited. Only thing is this has to be done in what we can say rapidly or spontaneous. It has to be done within 72 hours of the there, and the diameter should not be very big, it should be small one, and age should be greater than 14 years of the age of the patient. Then this can be helpful in that patients. So which is there, urokinase or TPA installation and aspiration, directly insertion of this with urokinase, or this other kind of, that is alteplase with minimum invasive evacuation phase 2. These are again surgical guided or laser guided techniques, or we can say just like angiography, we guide it and we put it there. For stroke, already I told you, basically we are doing it surgery, that means that inflammation is there. For that we are going for important this one, that is a decompression. So these are various surgeries are there, but I told you, I repeat again, that this is very rarely done until and unless it is really required, because surgery is not that easy thing. It is quite complicated, and it has to be done with very, very skilled person, and it requires a very what we can say maintained and very advanced setup, because you should have that kind of setup where these guided laser and the expert surgeons are doing it. So that is very, very important, and therefore it is not a choice immediately. Now there are various resources like NICE guidelines and many other guidelines are there, and there are various evidences levels are there which indicates what should be done. So basically these are the important causative factors which are there, which has to be maintained if it is known, because they can terminate into stroke. So hypertension has to be reduced, diabetes has to be controlled, hyperlipidemia has to be controlled, smoking has to be controlled, and if aspirin therapy is going on, then continue this aspirin into this, and it can be benefited. post-menopausal hormone replacement therapy should be given in the some of the females, but it is not recommended for primary stroke prevention. Rather prevention, it is although it may benefit in some of the patient, but it is not the first choice as a treatment. That stroke patient is there, and because of this hormone replacement therapy you can cover it. Alcohol, already we discussed that it should be avoided. So these are various ways by which we can use continue the aspirin anticoagulant therapy. Now again, who are the person who are very prone to this? If you remember, I have asked this question, I have not got answer. Is there any relation between arrhythmias? Whether anybody has tried to search it, arrhythmias and stroke? Anybody tried? Yes. What is the relation? Can anybody elaborate it?
Sir, the heart arrhythmias, they are mainly associated with the formation of blood clots. So in case when this blood clot it breaks, so it there is a chance that it
All arrhythmia, example, ventricular, supraventricular, there are variety of arrhythmias are there. Arrhythmias are always in heart only. We,
yes sir.
so what kind of, which arrhythmias basically they are more prone, or they are more responsible for this?
Atrial fibrillation.
Atrial fibrillation. What is the reason? I think I discuss it also, I repeat, I think. Yes.
Yes sir, I don't remember it completely, but means that clot formation, if it breaks, so it may travel to brain and it may cause
Okay.
blockage
Very
to
good,
blood
good,
flow.
good, good. So this is one of the reasons. So these people are prone. That means these are prone for that. Now, as soon as you understand who are prone, that's why I ask you to read this anticoagulant, in which patient it has to be given. So the person who are having arrhythmia, for them this anticoagulant treatment is given. The reason is this only, because there is no relation between anticoagulant and arrhythmias, or anticoagulants are not useful for any arrhythmias, and there are no effect on arrhythmias. They do not reduce any kind of arrhythmias. But once it has been found that these arrhythmias are responsible for formation of coagulation of blood, and these clots are formed, and this clot can travel to any part, particularly. Then one more disease is there that is very common, that is we call it as a this veins are there, that is DVT, that is deep venous thrombosis. So this DVT is again very prominent. Again, those which are there in these are the patients which are having, or they are diagnosed with hypercoagulability. So where the blood coagulation chances are more, such patients are there. So what happens is with arrhythmias, whenever there is a hypertension or diabetes, you know the complication it is causing. Hypertension can cause the friction in the blood vessel, it can cause the damage. If simultaneously there is a hyperlipidemia, then it will cause atherosclerosis, and these all will cause in total atherosclerosis, and it can be any part of the body. And as we have seen, if it is in heart, then there is a heart attack or angina. If it is in brain, then it can cause stroke. So these all causative factors, whenever they are found during any kind of diagnosis, then immediately treatment should be there. So we have seen that aspirin is beneficial, we have seen anticoagulants are beneficial, but heparin is reserved usually for the immediate activity. Whenever there, it is not a continuous treatment is given, because it will not reduce, and it is not easy also to give heparin continuously. Then people, they found that there are many neuroprotective agents are available for one, and or we call them as antioxidant, etc. But there are many trials are there, and they are not found to be very effective into that. So what are important or what are useful in these are aspirin, warfarin, then heparin is given, uh, particularly wherever there are chances of cardiogenic embolic, and anticoagulants are there. Now again, you have to go for this example I told you earlier, or you may just refer that which you read earlier in third year, that what is the problem, that warfarin has got so many problems. Warfarin is so far is very economical, one of the very good agent, but it has got one important problem is warfarin has got so many drug interaction, food interaction, and therefore it can cause the change in the warfarin concentration. And if anybody remembers, or if you just go for its pharmacokinetic, you will find that how warfarin is problematic, because majority of it, or almost more than 90% of it, is protein bound and various enzymes. So even that means only 1%, which is a free fraction, is responsible for action. So from this 90%, even if one more percent is released, not much, so still the active concentration doubles, okay, and vice versa. So this is therefore very tricky, and therefore it is always suggested that when the persons are on warfarin treatment, they should be continuously monitoring their INR, they should be continuously monitoring their dietary habits, because there are many food interactions, there are drug interactions, and they should be having very, very clear and regular life, then only they can go for warfarin. Otherwise, the newer agents are there, like dabigatran and all, which are acting on factor 10. Please go through the pharmacology, I repeat. Okay, these agents nowadays, they are preferring that. Yes, only thing is they are quite comparatively, they are costly, and the thing is the patient and doctor has to choose between continuous monitoring, because these require, the newer agents like dabigatran and all, they require comparatively less monitoring of INR, and therefore less hospital visits and less complications with warfarin, and these are benefits of that. Only thing is it is very costly, versus warfarin is comparatively, or it is very economical, but only thing is the care has to be done, and it has proven very effective. So if the person can take the care, then it is very important, and it is working very good, and it can prevent the further chances of stroke. So then there are various neurosurgeries, whether they should be performed. So carotid end arteriectomy, that is where the arteries are there which are responsible for that. So it is indicated for the most patient which are having stenosis, hardening. I told you it is very severe hardening is there, and even no drug will able to reduce it, because calcification of arteries are there in stenosis, and because of that it is so severely there that your drugs are not working. So in that cases you have to remove some of these arteries. So we call it as a carotid end arteriectomy, that can be working only if it is a small portion. If it is big portion, it is difficult. If it is earlier intervention, it is more beneficial. It can be indicated for the patient having stenosis of more than 50 to 70%. Definitely for 70 to 99%, drugs are not going to be effective, because there is a severe stenosis is there, and therefore only best treatment is this surgery, where you are putting another blood vessel into it, or you are removing this that stenosis portion and joining that artery. Then it is not recommended for the patient with stenosis is less than 15%, 50%, because I told you wherever possible surgeries are to be avoided. Okay, so it should not be given, and patient should be remain on antithrombic therapy before and after surgery. This is important. Then interventional neuroradiology should be simultaneously done. Angioplasty and stenting can be done, and it is a feasible alternative to carotid endarterectomy. But only thing is, again, it should be a small one. See, you can understand, if the blood vessel is there, there is a stenosis. Stenosis means calcification, rigidity, and very prone for occlusion, or reduce the diameter uh, very severely. So in that case, if the length of that area is very big, then the stents may not work, so you need to go for surgery. However, if the length of the stenosis area is comparatively small, then you can go for angioplasty and stenting. And then this is a feasible and comparatively easy alternative. Or feasible and easy means, I told you surgery is a difficult alternative. So definitely it is comparatively much better. And when surgery is undesirable, technically difficult or inaccessible, then we can give for that. Distal protection devices should be used during the procedure, and antiplatelet agents like clopidogrel should be initiated. The long-term safety efficacy is not very well studied, or it is not evaluated. Then next into is intracranial stenosis, asymptomatic. Then in that conditions, one can go for these activities, intracranial sealing of that. And this is also having good evidence level, that is evidence 2. So these are various stroke treatments, and you can simultaneously refer guidelines that these are first is identify risk factor. As I told you, they are very important. Pre-hospital care, take care about it. As I told you, there should be a separate stroke unit. Once stroke is cured, that is intensive care is there, evidence-based pathway we are using. Then go for neuro rehabilitation, and go for the maximum prevention using various activities. Then whatsoever problems are there, example, there is a paralysis, then go for physiotherapy. Then if hearing or etc. there is a loss, then go for occupational therapies, speech and language therapies. Psychologically, if they are depressed, then go for this kind of therapy. This is very important activity again in stroke, because the persons they are so depressed, or they feel that now brain has been affected and they will not able to get back to the normal work. So definitely normal will be affected when this rehabilitation has to be done. So this is how stroke is to be treated. I repeat, the just gist is what, basically only whenever cardiovascular or this stroke or any such problem is there, then our treatment is same, that is for atherosclerosis or just for myocardial infarction. Only thing is here we prefer altiplus or urokinase comparatively than streptokinase. We do not prefer streptokinase in brain. So in stroke related study, while in heart we can prefer streptokinase. Now then next thing is we have to use various anticoagulants. Again, one has to, and this is all you are doing after ensuring that what kind of stroke it is, whether it is hemorrhagic stroke or it is a ischemic stroke. For all whatsoever we have discussed now, this is ischemic stroke. If it is hemorrhagic stroke, then as I told you, or many times it can be combination of what, because of the ischemia, because of the obstruction, maybe after some centimeters, the force is there and there was an aneurysm, and this because of the aneurysm. Example, you have got a pipe, and in this pipe there was some debris is there which has occluded it. Now with force, when the pipe comes, the debris moves away, and while the debris moves away, it causes a small rupture in the pipe to what we call as an aneurysm, and the debris flows slightly away, slightly ahead, and because of that debris having a there is debris is there, when the this flow comes on that debris, the pressure is created on the this rupture, and from that there can be burst. So there is a hemorrhagic also and ischemic also. So in that conditions again you cannot use the agents, rather you should try for this angiographies, and with that if you can do the stenting, then that should be helpful, because you can remove it. But again it is not as easy as it is there in cardiovascular or in heart, because in heart it is comparatively easily it reaches to coronary arteries. Carotid are having comparatively difficulty, and therefore these things makes the thing complicated, and therefore the treatment becomes comparatively complicated. So as we have seen, if it is a hemorrhagic stroke, then unfortunately you cannot give any treatment to control this hemorrhage, because if you give it, then there are chances of ischemia or obstructions, and if you try to give any treatment for these obstructions, then you have to ensure that there is no aneurysm is present. So this is only the tricky situation that doctor is facing. After that, once it is simple ischemia, or we have seen the cases like transient ischemic attached TIA cases are there, or ischemic conditions are there. In that cases, treatment is very clear, very simple. If it is within 3 hours of the signs, then go for this tissue plasminogen activators, and maintain the patient on that is anticoagulant treatment. Depending on the condition, you can give aspirin, you can give clopidogrel, you can add warfarin. If it is having signs of hyperlipidemia, hypertension, go for the treatment of it also. And these all treatment has to be added as a maintenance treatment or as a follow-up treatment. So this is all about stroke. You just go through stroke, and if you have any difficulty, you can put in. So here we'll finish stroke. Then we'll go for what next topic I think we should go for. We'll just check it.